Yes, thank you. Professor Wada finished MD and PhD from Kyushu University and working now at Saga Handicapped Children Hospital in Saga Prefecture in Japan. He's a professor from Kyushu University. He had more than 20 years of DDH treatment, and he had published in English paper about 25 papers and more than 100 papers in Japanese language. Professor Wada, please give us a lecture.
Thank you for your introduction. I'm really happy to be here. So now I'm starting my lecture. Okay. Today's topic is about treatment of DDH. So tomorrow, neuromuscular pediatric hip deformity, and the day after tomorrow, I will talk severe hip deformity. Okay. So today, I will talk the basic concept of treatment of DDH. First of all, Saga is located in South Japan. Japan has 4 islands. As you can see, Hokkaido, Honshu, Shikoku, Kyushu, 4 islands. Tokyo is here, Osaka here, and Fukuoka. Fukuoka is a big city, and Saga is near Fukuoka. We call this island Kyushu. I have been working in Fukuoka Children's Hospital for over 10 years. So Dr. Tamanu visited Fukuoka Children's Hospital in 22, maybe it's true. And 2011, he visited Japan again as a Yamamuro Giwara Fellowship. Dr. Panya also visited Fukuoka Children's Hospital in 2007. Now, Fukuoka Children's Hospital moved to this artificial island near Fukuoka city. It's not rural, and it's located in countryside. So Dr. Amprasad visited as a Asian fellowship in Japan. So in Japanese society, we have several fellowships for foreign visitors, and please apply for these fellowships. Now, Dr. Panya kindly picked me up at the airport, and I remember I worked with him, and I have submitted and published several papers with Dr. Panya about congenital dislocation patella and after infection and sepsis. Now, Saga Handicapped Children's Hospital is built 50 years ago, but new facility was built 5 years ago, so it's very new. So we have dormitories near our hospital, so you can visit us. Please feel free to contact me if you want to visit. So Saga, it's very famous, balloon festa. So near the river, there are balloon festivals like this, and it's very beautiful. We have a hot spring place, Takeo Super. It's very nice. And there is another big festival, Karatsu. So big people are carrying big fish and near the shrine. So in spring, Yutoku Inari Shrine, it's very beautiful. You can see cherry blossoms in spring. They are full bloom. And near Saga Handicapped Children's Hospital, we have a river, and there are many fish floating in the sky, and you can enjoy riding a small boat on the river. So in fall, so fallen leaves and leaves color of leaves changes to red, and it's very beautiful. Okay. Now I start my talk. So, etiology of DDH. Before 1970, it was 2.3%, but the rate reduced to 0.3%. So at this time, so preventing program was introduced in Japan by Dr. Ishida. So changes the shape of diapers and change clothes, the styles of clothes, and so koala hugging. So moving the action like this, the rate of DDH extremely reduced to 0.3%. So we have DDH in 0.3% patients. So left is, the number of left is larger than that of right, about 3 times. So female to male, about 5 times. So bilaterally seen in 20%. So DDH risk factors, as you know, breech position and first baby. Maybe pelvic is tight to breech first baby. So born in winter. So Japan has clear 4 seasons. So in winter, it's very cold in North Japan. So patients, babies wear a lot of clothes. So it's tight. So DDH was seen in winter. So as you know, family history, maybe the shape of pelvic is similar to the parents. So it's the old data. So summer is small. The rate of DDH is small in summer, but the rate is much higher in winter. So the diagnosis of DDH at the time of 4 months, so there's no ossification on femoral head. So von Rosen radiograph is effective for diagnosis. So as you can see, the femoral shaft goes to hip acetabulum, but if it's dislocated, it doesn't go to hip joint. So as you can see, Wallenberg line here and Ambledan line here. So you can see the hip joint outside of the 2 lines here. You can see a clear central line on normal hip, but interruption of central line on dislocated hip. Acetabulum index, as you can see, much higher than that in dislocated hip. You can see clear curved line here, but it's not determined in dislocated hip. It's not clear. So the treatment of DDH is, first of all, a public harness. So as you can see, the belts, you can see the belts go through the bodies, and under 6 months, we do. After 6 months, babies can move by themselves, kind of rolling or sitting. So it's difficult to be. It is not effective for babies to be treated by public harness. So I treat under 6 months. And as you can see, the Wallenberg line, and from the distance, for the distance of femoral neck, this is distance A proposed by Yamamuro. So distance A is over 5 millimeters, public harness is used. So the indication is not, it's not indicated for high dislocation. Under 6 months of age, and distance A is over 5 millimeters, we try public harness. We decide it's reduced or not within 1 week. If it's not reduced, irreducible, we retry again 1 month later. If the patient's hip is reduced, we'll continue the treatment. So as you can see, if it's not reduced, again, traction and closed reduction is attempted. So we try twice. And at the time, if it's reduced, we go on the treatment. So if it's reduced, so patient's hips are kept in 90 degrees flexed for a month and gradually to 45 degrees flexed positions. Total we apply 4 months. So this is to prevent lateralization after removal of public harness. So this is the treatment strategy of public harness. I show you that typical X-rays of public harness treatment. This is 3 months. 3 months, the diagnosis. As you can see, the femoral head is here and dislocated, and a public harness treatment is done and reduced. As you can see, the hip is reduced, and femoral ossification center appears at 7 months. You can see the hip is seem to be subluxed, but it's a natural cause of lateralization. It will recover soon. At 1 year, 6 months, the position is good. So you can see 5 years of age, 10 years, 12 years, and at the end of the follow-up, the hip is very good. So from 2007 to 2016, 143 hips were treated. So age at public harness was average at 3 months. So reduction rate is 72.7%. As you can see, the male and female. Female is much higher. I'm not sure why it is. So vascular necrosis was only 3.8%. So if you increase the number of reduction, so a vascular necrosis may happen in higher rate. So the reduction rate is, I think 70% is appropriate for public harness. So you should move on to the traction if it's not stable. So as a summary, so under 6 months of age and distance A is over 5 millimeters, public harness is used. If it's not reducible, it's reducible, it's not reduced, traction is tried. Traction, we'll move on to the traction. So if distance A is below 5 millimeters, also traction is a fast treatment. We don't do the patient with high dislocation, we don't use public harness. So fast traction. And 6 months to 3 years, we do traction. Okay, so the treatment of traction is reducible public harness, high dislocation, and the age from 6 months to 3 years. And horizontal traction is made for 2 weeks. After that, distance A is usually above 10 millimeters. So over 5 millimeters, close reduction is attempted, but we continue the traction. So it's a first step to change the treatment. Okay. So horizontal traction for 2 weeks, and upward vertical traction for 1 month. So if the hip is stiff, open reduction is, we change the treatment to open reduction, but it doesn't happen. In almost all patients, we go on the treatment. So vertical traction for 1 week, and abduction traction for 1 week. So totally 4-week traction. After that, under general anesthesia, the hip is reduced. So if it's stable, we apply for cast. So reduced in hip, between hip abduction from 60 degrees to 90 degrees. If it's stable in this range, we will try cast. And after cast, we use flexion and abduction brace and Hoffman-Daimler brace. So total for 6 months, orthosis treatment. Okay. So at the time of closed reduction, it's unstable. Open reduction, we change the treatment to open reduction. So it's a typical X-ray of traction. So this patient is 1.6 years. It's a neglected DDH after walking age. Traction was performed, and at the time of closed reduction, arthrography is performed, and we see the stability. So at this position, we use cast, and after that, 3 months, 3 years, 5 years, and 9 years. So you can see the acetabulum recovers very well. So at the time of 13 years, the hip is almost normal. So the causes of failures of closed traction and closed reduction, it's one major cause is insufficient traction. Traction is insufficient. Closed reduction should not be attempted. Or there are some cases I treat after at another hospital. So I see these types of casting. You can see the space around the baby's bodies. So the cast is very loose. So it's dislocated. And so tight cast is necessary to keep the patient in reduced position for 3 weeks. So it's necessary, especially in unstable hip. So traction and closed reduction. During 7 years, 87 hips in 82 patients. Average age was 10 months, from 3 to 36, 3 years, 3 months to 3 years. So bilateral hips were 10 hips. So reduction rate is 96.6%. Almost all hips were reduced. So open reduction was performed in only 3 hips under 3 years if the patient come to a hospital initially. So very high. Almost all hips are reduced. And a vascular necrosis rate is only 5.7%. The results are very good. But about 30% hips will require pelvic osteotomies because acetabular coverage is not enough, the shape of the acetabulum cannot recover well in 30%. And you can see during the traction, distance A is below 5 millimeters, open reduction. Similarly, close reduction was unstable or dislocated, open reduction is performed. But now it's only 3% in a hospital. And over 3 years, we will do open reduction. Open reduction we use is maybe you are doing as well. So adductor tenotomy here and anterior approach. So you can see ligament teres, it's removed, and you can see the inside of acetabulum. We remove interarticular obstacles such as ligamental teres, fibrofatty, pulvinar tissue, and we cut the transverse ligament. And after surgery, we repair capsulopathy, and finish the surgery. So you can see the failed public harness. You can see a very high dislocation. And traction and close reduction were tried, but we dislocated. And open reduction was performed at 11 months, and 3 years, and 18 years. The result is very good. And I move on to the residual subluxation. So it's the data from Dr. Kobayashi. He's working in Kobe Children's Hospital. So he compared the normal hip to acetabular dysplasia. The C angle changes from 6 years, as you can see. And the recovering rate is much less than normal hips. So I set the C angle for 5 degrees at 6 years and 15 degrees at 12 years. So my indication for surgery is 5 degrees under 6 years and 9 years, 10 degrees, 12 years, 15 degrees. So the typical X-ray. So this is C angle minus 5 degrees and acetabular index over 30 degrees. So at the time of 12 years, it's difficult to measure acetabular index, so I use sharp angle. Sharp angle over if it's over 50 degrees, we indicate pelvic osteotomy. Under 6 years, SOLTA. At around 9 years, pemberton or triple, and 12 years triple osteotomy. So SOLTA osteotomy, as you can see, this giggly saw. So put the sciatic notch and push up the osteotomy. Now I use this slide upward and draw distally to prevent lengthening of pelvic. But it's a slide of just put it upwards. And so move the distal segment anterior to lateral, and pin fixation for bone graft, and place wires. So 71 hips, the average age was 3.5 years. So clinical evaluation, Marquez clinical criteria was used, and radiographically, acetabular index, Sharpe's angle, C angle, and Severin's classification. So overall, SOLTA osteotomy is good. So usually, under 6 years, patient doesn't have pain, almost in 46 patients, but I do surgeries if the subluxation is severe. Severin's classification is dramatically improved. So as you can see, 5 years, throat osteotomy was performed, and finally, good. On the other hand, this patient isn't performed surgery. Subluxation remained. So this patient was graded as Severin 3. So it's a difference of treating pelvic osteotomy or not. So the result is becomes worse if the patient has avascular necrosis. So as you can see, it's not treated. But the shape of the femoral head is good. This patient was graded as Severin 4. And open reduction and suture. This patient recovered after surgery. Very nice recovery. This patient, similarly open reduction and suture. I graded this patient as Severin 4, but the shape of the femoral head changed well, even though femoral neck deformity remains. Now I do some kind of rotation osteotomy. I will show you the slides the day after tomorrow. Tomorrow, I will show the surgery for these patients. So I will talk about another osteotomy, Pemberton osteotomy. As you can see, the osteotomy line here is oblique line. So you can see the fragment movement anterior to lateral. So bone graft is inserted here, and usually no wires. So similarly, 70 hips were evaluated. At the time, age at the surgery, 9.3 years. And overall, the results are good. But about 30% subluxation remained. So Pemberton osteotomy is not enough for elder children. We have to combine various osteotomy. Well, another osteotomy should be, such as triple osteotomy should be chosen. I will show you the slides. This is a 9-year-old bilateral DDH treated by public harness. So Pemberton osteotomy was performed here, and results are good. But on the other hand, right hip was not treated. The same patient, right hips subluxed. So this patient has pain, so we have to treat this hip. So the results are definitely different among these two hips, left and right hips. And this patient has slight avascular necrosis. Pemberton osteotomy was performed, but it doesn't cover enough. So various osteotomy and distal transfer of greater trochanter was performed. And the final results are Severin 2. Shape of femoral head is good, but it's not good enough. So at this time, various osteotomy should be combined. But now I use a triple osteotomy for over 9 years. I'll show you another case. This is similar, Severin 4. And for this patient, Pemberton osteotomy and dilatation various osteotomy was performed. But insufficient coverage. Coverage is not enough for this patient. This patient had pain at this age, so triple osteotomy was performed. I use a single incision here. I can do triple osteotomy from anterior single incision or lateral single incision. So it's much easier to move the fragments by single incision. Like here. So final results is very good. So pain reduced. So at this time, triple osteotomy can be another option for this patient. So I'll show you two patients after open reduction. This patient is re-dislocated hip after open reduction and Pemberton. This patient was not noticed until 2 years and 9 months, so neglected re-dislocation, and she had severe knee ingate. So she consulted us. So as you can see, excessive anterior coverage. So hip is dislocated posterior, and ilium lengthened and deformed at the site of the harvested bone graft. As you can see, the acetabulum, base of acetabulum is widened. And as its 3D CT is a very nice tool to diagnose for this patient. In MRI, the femoral head is deformed ovally and dislocated posterior. So for this patient, I used is posterior coverage. So as you can see, anterior side is not cut here, and the osteotomy line moves to posterior, very posterior, and at the posterior side, a bone graft is used. I use this osteotomy for this patient. So as you can see, no osteotomy line anterior. So after surgery, you can see from anterior side, I don't cut here. You can see anterior, posterior side, a bone graft here. So laterally, so posterior side, bone graft is used. So you can see posterior side, big bone graft, and only moves the fragment to distal part. So before surgery here, and after surgery, as you can see, the bone graft is here, posterior side. So for this patient, so now she is 5 years, 6 months. The whole standing X-ray, it's very good. Scoliosis improved. The last patient I show you today is left hip deformity after open reduction and Salter. So she had knee ingate, hip pain, and low back pain. So I don't use open reduction because somehow femoral head deformed like this. So leg lengthened, and so knee ingate occurs because of hypertrophy, valgus deformity, and anteversion. As you can see, pelvic is oblique, and you can see the scoliosis. So leg length discrepancy is 1.8 centimeters. So you can see the knee ingate for this patient. Impossible to sit cross-legged. In Japan, many people like to sit in cross-legged position. So internal rotation, 100 degrees, and external rotation, 20 degrees. Before surgeries, external rotation is limited. Okay. internal rotation and external rotation. So due to anteversion of the hip. So I used dilatation and varus and shortening osteotomy for this patient. Now I use locking plate. LCP hip plate is used for this patient. Almost all femoral osteotomies I used LCP hip plate. I'm not sure this device is available in Thailand. I use after surgery. Almost equal internal rotation and external rotation. Okay. So at the time of 13 years preoperatively, so you can see the leg length discrepancy and scoliosis. But after surgery, leg length discrepancy reduced and scoliosis improved. The final result is good and the pain reduced for this patient. Okay. Thank you for your attention.